And if you saw that, you saw whistle stop tour before we began. So thank you for inviting me to talk this evening. I wanted to talk about sterile water injections for use for women with back pain and labour, because I was one of the leads for Site 15 of the Icarus trial. And Icarus stood for the impact on caesarean section rates following injections of sterile water. It was a CTIMP, which is a clinical trial of an investigational medicinal product. And it was a randomized, double-blind, placebo-controlled trial. The majority of sites were in Australia, and when I was working in Oxford, it was the only UK site. So it was a midwifery-led trial, which was incredibly exciting. They picked the topic of looking at impact on caesarean section rates because some of the smaller studies had suggested that there might be an impact on caesarean section rates. And we'll go into the findings from the trial afterwards, but it certainly enabled us to get funding for the trial, as well as looking at the secondary outcome, which was about the effects in terms of pain relief. So this is what NICE guidelines says just now, and I'm very proud to say that the trial that we were involved in actually influenced the change to NICE guidelines. So I think that's a really important thing for future midwives or midwives out there when you're doing research, is that you can have an impact and lead to national change. So NICE, prior to the findings of our research being published, used to say do not use. They referred to it as water papules. And now that this is their stance, and I will share a few of those as we go through this evening. And I think, you know, the biggest message I think to go out from our discussion about sterile water injections is you're not trying to deny people of other methods of pain relief. What you're actually trying to do is introduce an alternative for them that would not affect their choices to go on to have other methods of pain relief if they won't. But it's a very cheap option and can be used in any birth setting. So it's quite an exciting thing for us to be able to offer to women. So what are sterile water injections for people that don't know? It's if anybody's given or seen a BCG, you are creating a bleb like a BCG on points in the back. And what happens is you inject sterile water just underneath the skin in 4 points in the back, and it causes an osmotic and mechanical irritation. There is significant pain associated with it, and that is really important that that is acknowledged, but it does pass incredibly quickly. And we'll talk about that when we get to the point of administering it. And what all the evidence is showing is that pain relief follows almost immediately and is there for up to 2 hours afterwards. So this is the kind of physiology behind it. So gate control theory of pain was quite a revolutionary pain theory. So I'm going to try and make a simple explanation of quite a complex process. So excuse me while my brain thinks, but it's a neurological gateway exists in a portion of the dorsal horn, I'm not going to be able to say it properly, called the substantia gelatinosa. And basically there's densely packed cells which remain open to normal and constant transmission of nerve impulses from peripheral fibers to cells of the spinal column. And essentially what happens is a gate that remains open to the normal and constant transmission of the nerve impulses from the alpha delta to the C nerve fibers. So that's a big explanation, but it's working on the gate control theory of pain. You're trying to shut off those messages from ultimately getting to the brain. And they also refer to this diffuse of noxious inhibitory controls. This is LaBar. And basically, if you have two pains working together, but not in the same part of the body, the stronger weakens the other. And this is like my description of a sterile water injection. It's like a sharp shock. it shocks the system, and the body goes, ow, to that pain and forgets the other pain that's been causing the compression of the nerves and the viscera, which has caused that intense referred pain that women experience in their back. And so when you think about women, oh, sorry, excuse me, going back. I'm just hoping your slide isn't blocked by my bit at the top of my, here we go, got rid of it. So in terms of back pain and labour, there's roughly about 30% of women experience intense back pain in labour, and that's known to be a referred pain. People have commonly felt that it was from an occipital posterior position. And actually, when you look at a lot of the trials, they've actually talked about, you know, is it actually that the baby is in an OP position, or is this baby a malposition? It's deflexed and it's unable to do that descent and rotation. And because it's pressing on those nerve endings, it's causing this quite intense pain, and the body responds to that by clutching the muscles, which basically holds that baby up and stops that baby from descending into the pelvis. It's more common in nulliparous women, and I think a feature of this back pain in labour is actually it tends to persist through the uterine resting phase, and obviously gets more intense when there's a contraction. And the reason we looked at caesarean section as one of our outcomes was because we all know that malposition, that lack of descent, you know, a deflexed baby's head is you're more intent to get like a labour dystocia, you have a longer labour, and obviously if you have increased pain, you're more likely to require something else to help you to cope. And that longer labour, then you're more likely to require intervention to help you progress in labour. So it was really important for us to think about how we could make a difference to that. And actually, within the research, we actually found that out of, you know, the women that we looked after, 40% of those women had a baby in an OP position, and it was the other 60% were between OA and OT, but obviously they were from a deflex position. So that's why we always go, back pain, it must be OP. So what we want to do is change that thought process to say, actually, it's more likely due to a deflex baby's head. So this is the evidence. So this is the trial that I was talking to you about. It was, like I said, it was referred to as Icarus. And it was published in the Lancet, and this is what has led to the changes in national guidelines. And actually, it was what enabled us to bring it into our unit, because very much have been some units around the country who've introduced sterile water injections before, you know, the trial was published. But, you know, in organisations generally, we're promoting evidence-based practice. So it was very important to have that evidence, and it enabled, you know, a tertiary referral centre to say, OK, we have the evidence now, we have to promote this and push it forwards. And it was actually our research department that actually pushed forwards with changing the changes to national guidelines. So hopefully this is easy to access. You'll access that, and there's a reference list as well. So this is again from NICE guidelines. So it's about explaining to women that they can get almost immediate relief from that back pain, and it can last for hours afterwards. But it's interesting their use of the words. It's an initial stinging sensation. When I describe this to women, and I've counselled women, obviously, for these injections, we gave a lot of them in the trial and then afterwards, it's painful. On a scale of 1 to 10, having that injection is about a 10, or it was for us. So it is a sharp shock. It makes you go, ow, but it literally lasts for 10 or 20 seconds, if that. And the art is, this woman is in intense pain anyway. If you looked after people with back pain in labour, you will know that they speak very much about, they feel like their back's going to break, that people are stamping on their back, you know, that it's just intense anyway. And then when you add a contraction, it gets even worse. So what we do with the sterile water injections is we say, well, look, we're going to give you a pain, but we'll give it to you during your contraction. So when you're at that height of the pain, you'll have it. And then the injection is finished before the contraction is actually finished. And actually it can immediately, and it can be literally like flipping a switch, turn off the back pain for that woman. So if the woman says, you know what, I don't fancy that, that sounds horrible, my pain is bad enough as it is, I don't want it, that's absolutely her choice. But if she thinks, well, do you know what, I hate this, I've had this for X amount of time, if there's a way that you can, if I have to just take one more contraction when it's really intense and there's the potential that that stops, for a large proportion of women, that is a good option for them to do. So I think that's one of the key things in terms of, it's really important that you tell women about that, because if you don't tell them about it, they won't believe you for anything else you tell them for the rest of that labour. So, you know, it is really important to be open and honest about it. So these are the results of our trial. So this is looking at the time of injections. And the reason there are these 50% and 30% is because in terms of when you're looking at research for pain relief, they talk about women having 30% relief from pain or a 50% relief from pain, is in terms of showing the efficacy of whatever method you're doing. Although it is really interesting to know they haven't used those same efficacy grades for things like pethidine in labour either, but they did use it for sterile water injections. And I think you can see hopefully quite clearly from that when you're comparing the sterile water to the placebo, which is saline, you can see that there is some benefit from the saline, but there is more than double benefit in terms of the women who have sterile water. And the explanation, I'm sorry, I haven't given you before, is why does saline actually work? Because saline will provide a brief stinging sensation. It very much does. It's not nearly the same in terms of pain threshold as sterile water, but because of the osmotic effect, saline just disperses and it doesn't keep the bleb that stays there with the sterile water. So it will provide some initial relief, but it won't go on to provide any prolonged effect. And this is what women say about the effectiveness. So, you know, I think when you're looking at that, you know, again, the difference, you know, you've got double the women or more than double the women are saying it was very effective. There are obviously going to be some women that say it wasn't as effective. And there were some women, and if I can use an example of a woman in labour who she was somebody having a second and subsequent baby, and she came in and her labour was she was stuck. She'd been 4 centimeters, 4 centimeters, 4 centimeters, and she said, I've had it, I want to have an epidural. We talked to her about having the sterile water injections. And we called the anaesthetist because we weren't there to stop her from having it. They said, oh, I'll be down in about half an hour. She said, you have to do something now. You know, this is just as it was. I can't cope any longer. So she went for the sterile water injections and we gave her them. And literally, I think we turned around to put the needles into the bin and all of a sudden we had a baby. And certainly before the anaesthetist got down the corridor. And it was, from her perception of it, she didn't need that injection because you know, she was going on to have her baby. But actually, was it that she was just going on to have her baby? Or was it that it was the injections took the back pain away that enabled her to relax and birth her baby? And you'll never know which one it is. But that's why when we look at the comments in terms of people saying, I didn't think it was effective, it's because predominantly they birthed their baby really quickly. We also had a nulliparous woman who, again, I think she was stuck at 2 or 3 centimeters. And really wanted to go into the birthing pool, and we said, well, look, you know, she'd horrible back pain. We said, look, do you want to have these injections first? We gave her the injections, and then by the 5 or 10 minutes later, when we're getting her into the pool, she put her leg over the side of the pool, and luckily the midwife caught the baby before it went into the pool. So, you know, we have lots of stories and experience around it. We have the data, and I'm absolutely showing you the data, but I wanted to share with you that it's really quite amazing when you use these sterile water injections. It certainly amazed me how quickly you can turn off that back pain in labour. So we asked the women, did they feel satisfied? And again, I think you can see that the majority of women did feel satisfied. And again, thinking, why wouldn't they feel satisfied? You know, again, did they see the link from the effect of that to them birthing their baby? And then, but would you have it again? And again, you've got a proportion, you know, more than half the women said, absolutely, I'd have it again. And some that were saying, no, didn't like the pain, wouldn't do it. And that's fine, because it's choice, isn't it? And it's really important that women have the choice. Would they recommend it to others? I mean, I think when you get, you know, almost 70% of women saying, yes, I would recommend it to others, then that's incredibly positive. And I should have said, in terms of the questionnaires for the pain scores afterwards, we had 70% of women responded. So out of the 1,166 women in the trial, 70% of them gave us their feedback on all of these questions that I'm sharing with you. So very important when you're talking to women, what are the advantages of sterile water injection? It doesn't have any effect on the woman, you know, in her level of consciousness. It doesn't cross to the placenta. It doesn't affect breastfeeding. It can be repeated. And like I said, you know, it very often enables them to continue in labour and birth their baby. In terms of the disadvantages, you have to tell them about the pain, like I said before. It is, at present, it's only limited to back pain and labour. I know that the Australians are looking to extend the trial to look at it for use in other aspects of labour, but just now our evidence base is all on back pain and labour. So if it's a woman that doesn't have intense back pain, it won't necessarily work for her. And with any pain relief, and this applies to your morphine, your pethidine, whatever, you know, there are a percentage of women that it doesn't, around 5% of women won't get pain relief from it. So now I'm just going to talk through how you actually give the sterile water injections, and I'm probably way over time, I'm very sorry. I'm going to speed talk this because you'll have the slides anyway. So we use 4 different points around the Michaelis rhombus. I've talked about the bleb. You have to find the right point to get your Michaelis rhombus. For some women, it's really clear, and you put 4 injections into her back. It's ideal to do it with 2 people, and you're doing it at the same time, so that you both say now and now, so that the woman isn't having to go through having 4 injections. This is the equipment that you need. So I think in all, it probably costs about 30 pence to give sterile water injections by the time you look at the cost of the sterile water and the syringes. And this is what it looks like on somebody's back. So you can see the blebs that occur, and the blebs should be about a 5 pence piece, and they're very superficial towards the skin. And then I'm very quickly going to show you what that looks like in practice. So you can see they're deliberately using a marker pen, and it looks like a permanent marker pen, but please don't use that on women. They don't need that kind of evidence that they've been in labour and had their babies. So, you know, they've identified their 4 points. And this was filmed in Australia. We use this as part of the training for the trial. And then you're going to see that they're basically going to go round about, and they do it together. So they're both looking at each other and saying, this is what we're going to do. And even when you see this result, you will see that the bleb on the right hand side at the top is much better than the one on the left. it's a bit closer to the top of the skin, and at this point, when you do put that injection in, she is going to yelp, and that is it. So I did have another brief slide summarising, but I have really overrun my time, and I do apologise to Denise for that, and happy to take questions later. But a lot of the information is in the research paper and in NICE guidelines.